Excellent. Thank you. So, Assalamu alaikum, everybody. Thank you very much for having me here. It's a privilege to be able to talk to your students, and I am pleasantly surprised to see so many people logged in at so early in the morning in the month of Ramzan. So, my topic today is I'm supposed to talk about disc herniations, lumbar spinal stenosis, and lumbar listhesis. And so these things, all the three of these pathologies are can happen in any part of the spine. But in today's lecture, we are only going to focus on the lumbar spine, where it is incidentally more common, much more common. For a regular spine surgeon, in fact, for any neurosurgeon, these three pathologies account for almost 90% of the spine workload, for both operative cases and non-operative cases. So it's a must know. These are not optional topics for neurosurgeons or neurosurgery aspirants. Also, these are important to know because a lot of times, in fact, more pathological than physiological. So these conditions are present in normal populations, so in people without symptoms, and therefore it's important to differentiate them from pathological conditions which require treatment. Okay, so since this session is more to do with neuroradiology, so we're going to go over these slides and talk about normal anatomy and normal radiology, and then talk a little bit about pathological conditions, their symptoms, their management, and maybe open this up for discussion. Please let me know if at any point the slides don't show as they should. All right. So I have nothing to disclose. Actually, I do have something to disclose. Most of the slides have been copied from, and none of these cases are mine. So please excuse my laziness. All right. So this is a standard mid-sagittal T2 weighted MRI scan of a lumbar spine. All right. And why am I saying that this is T2 weighted image? Because as you can see, the CSF looks white. The fat looks white. The bone looks gray. Why am I saying that this is mid-sagittal? Because you can see the spinous processes. And unless you're dealing with a scoliotic spine, a mid-sagittal view will show you all the spinous processes and the maximum girth of the spinal canal. So what are the normal, and also if anybody has any questions, instead of putting them in the chat window, which I am unlikely to access, please feel free to unmute yourself and interrupt me, so we can talk about that then and there. Okay, so yeah, so this is a mid-sagittal view of a T2 weighted MRI scan of a normal lumbar spine, and you can see, so we're going to go over normal anatomical structures that you see here. These are, of course, the vertebral bodies. These are the discs, and you can see that the height of the discs vary according to the level, even in lumbar spine. As you go down the level, the disc heights become more and more. Also, the angle of the disc start becoming more. So you see, for example, here, अच्छा इनको count कैसे करते हैं? ये L5 है. So this is S1, 5, L5, L4, L3, L2, L1, T12, L1. So 5 lumbar vertebra, sacrum, or thoracic vertebra. And as you go down the lumbar vertebra, you can see that the angle of the disc becomes greater. So the posterior angle posterior limit is narrow and the anterior limit becomes broader. And that accounts partly to the lordosis that you see in the lumbar spine. And then it gradually curves into the sacrum, and there's the lumbosacral angle. and you will see a lot of variation, just like physical variations in the human body, even at anatomical level, you see variations at all levels. More so in the lumbar spine, because here the variations are not only because of genetic reasons, but also because of environmental factors. How much does the patient weigh? Does he look after the back or not? Does he have any other conditions? And all of this has influence on the patient's anatomy over time. जैसे यहाँ पे आप देखें तो disc, so these are healthy discs, and that's why they look white on T2, because 70% of the disc is water. ये पीछे spinal canal है, ये यहाँ पे conus है, और conus के नीचे conus medullaris और नीचे cauda equina शुरू हो रहा है, and we call it cauda equina because in Latin that means a horse's tail. So ये horse tail की तरह सारी nerve roots नीचे hang कर रही होती हैं और फिर अपने अपने level पे एक एक करके ये exit करती हैं, right? And these are spinous processes. And अच्छा यहाँ पे the three vital structures that you see here: the bones, the ligaments, and the joints. Joints यहाँ पे नजर नहीं आ रहे, मैं आगे बताता हूँ, but the joints you can see here are the intervertebral joints. So bones में अगर हम anatomy देखें तो vertebral body के आगे लगे होते हैं anterior, कौन से ligaments लगे होते हैं? Anybody? That this will also tell us whether you're awake or not, and whether you can unmute yourself and participate.
So the anterior
spinal ligaments. Hani also is anterior spinal. So anterior spinal ligaments in the front, and then यहाँ पे we have disc. So disc के भी दो parts होते हैं. You guys will remember the annulus fibrosus, which surrounds the disc, and the nucleus pulposus in the center. इसको हम आगे और बात करेंगे. And then पीछे अगर आते हैं यहाँ पे तो posterior spinal ligaments होते हैं, right? फिर आपकी canal आ जाएगी, और फिर इधर ligament of flavum होता है, which are attached to the ligament, to the lamina above and the lamina below, and then interspinous ligaments होते हैं, और फिर supraspinous ligaments होता है, और फिर ये fat और skin. अच्छा, now this is, यहाँ पे अगर आप देखें कि तो canal is wide. अच्छा, दूसरा इसमें भी बड़ी variation होती है. You will not always find the same diameter canal. Even asymptomatic patients, even normal spine patients. So for example, this is a lucky patient with a wide canal, good disc heights, good vertebral bodies, good alignment, good lordosis. On the other hand, this patient has an even wider canal, but the angle is more. And here you can see that the disc heights are not as much as the patient that we the person that whose MRI we saw prior to this one. And the angle is more acute. The lordosis is more pronounced. I wouldn't call it exaggerated, but there are ways to measure this angle, and the normal variations. But that only matters if the patient is symptomatic. You don't asymptomatic patients may doesn't really matter, because that's not something that you can change, right? So जो ligament of flavum होते हैं, उसकी बड़ी interesting attachment होती है. यहाँ पे हमें lamina दिखनी है, so we go to an image where we can see the lamina, so we can talk about it. So this is an axial image. Again, T2 weighted MRI scan, lumbar spine. This is taken at the level of the nerve roots, so you can see the vertebral body in the front, right? The spinal canal, the nerve roots. This is all CSF. This is where the nerve roots are exiting, and यहाँ पे पीछे facet joints है. अब और ये lamina है, and that's the spinous processes. ये पीछे कौन सी muscle group है? This is erector spiny muscle group of the quadratus lumborum. आगे psoas वगैरह आती है. And these are the erector spiny muscle group is also very important, because इसके ऊपर lumbar fascia होता है, and these also contribute to spinal stability. अच्छा, इसमें भी इस level पे अगर हमने देखा, so if you go back to this cut. So ये जो हम axial देख रहे हैं, वो देख रहे हैं हम disc के level पे, right? इसी को अगर हम body पे देखें तो कुछ और है. So ये disc का level है almost यहाँ पे, and there's a little bit of bone here also visible. और ये foramen यहाँ पे दिख रहे हैं आपको, nerves दिख रहे हैं. Facet joints also something of which vary, like your fingerprints. It's different in every single patient. Depending on your genetics as well as your environmental factors. And this is the angle of the facet joint, and I want you to look at it very closely, because as we see more axial images, you'll see how the angle varies and the size of the facet joint varies, and the size of the capsule varies, and the synovial lining varies. And as the facet joint changes in size, you will obviously, just as इसके structure, you will see that the foramen also becomes narrower, the canal becomes narrower, because आप देख सकते हैं कि कितना करीब करीब है facet joint और canal के साथ. तो अगर facet joint समझे फॉर एग्जांपल इस पेशेंट में डबल हो जाए साइज में, तो ये ऑटोमेटिकली कैनाल को नैरो कर देगा. और जिस तरह facet joint एंगल पे होता है, सो ये कैनाल यहाँ पे आपको राउंड दिख रही है, लेकिन अगर इस जॉइंट को हम बड़ा कर दें यूं करके, तो ये कैनाल यहाँ पे आपको ट्रायंगुलर बननी शुरू हो जाएगी, राइट. अच्छा, इसी तरह अगर ये facet joint का एंगल हम चेंज करते हैं, यहाँ पे यूं एनलार्ज होना शुरू हो जाए इस एंगल पे, तो यू विल नोटिस naturally the lamina will become smaller, right. तो जैसे जैसे जॉइंट बड़ा होता है, लेमिना को इंक्लोज करना शुरू होता है, लेमिना छोटी होनी शुरू हो जाती है. अच्छा, ये लेमिना के नीचे यहाँ पे this is the ligamentum flavum that we were talking about, a very vital structure here. और ये जो white दिख रहा है, this is the fat जो हमें स्पाइन में दिखता है. Now, because this is all all of this works as a single motion segment. The joints, the ligaments, the vertebral bodies, and if one of these structures is affected, the rest also gets affected. So for example, अगर इस पेशेंट को डिजेनरेशन हो जाएगी इस लेवल पे, इसमें क्या क्या होगा? इसमें जिसकी हाइट कम होनी शुरू हो जाएगी, facet joint बड़े होने शुरू हो जाएंगे, facet joint बड़े होंगे तो कॉम्पनसेटरी लिगामेंटम फ्लेवम थिक होना शुरू हो जाएंगे, लिगामेंटम फ्लेवम थिक होंगे तो ये ऑल कैनाल नैरो होगी, राइट. अच्छा, अब ये सब जॉइंट्स बड़े होंगे, लिगामेंट फ्लेवम थिक होंगे, कैनाल नैरो हो रही होगी, डिस्क हाइट कम होगी, फोरामेन कम होना शुरू होंगे, तो कैनाल की जगह कम होना शुरू हो जाएगी, नर्व पर प्रेशर बढ़ना शुरू हो जाएगा.
So sir, we have a question in the chat box. What would you like to take all the questions at the end or in the middle?
नहीं, जो यहाँ पे आ रहे हैं उसकी यहीं पे बात कर लें.
अच्छा, so it's basically about how does this axial get differential from the arachnoiditis in T2 axial view. So I think we haven't talked about this yet.
Well, we can talk about arachnoiditis, but I think चले आखिर में टाइम होगा तो बात कर लेंगे इसमें वासिफ, इसलिए कि arachnoiditis is a different because यहाँ पे जो स्टूडेंट्स हैं उनको तो इसकी इतनी नहीं आएगी ना.
Exactly, and we are talking about the stenosis and listhesis. We are not talking about the arachnoiditis and other inflammatory and infective condition in this lecture specifically.
All right. Right, so this is another axial view, T2 weighted images. ये जो है वो pedicles के level पे लिया गया, ठीक है. So if we go back here, so this is mid sagittal view, इसलिए आपको यहाँ पे pedicles नजर नहीं आ रहे. Yeah, so ये axial view pedicles से लिया हुआ है, and you see a different anatomy here. The joints look smaller because जैसे आप नीचे आते हैं इसका size कम होना शुरू हो जाता है. But यहाँ पे if you compare it to this axial view, I'm sorry, we were on this one. We were still on this one. So इन दोनों views को भी आप देखें, so ये facet joints यहाँ पर कैसे दिख रहे हैं, कितने अच्छे facet joints हैं, इनकी margins कितनी clear हैं, इनकी size okay. The lamina is symmetrical, the spinous process is in the midline. On the other hand, अगर आप यहाँ पे आते हैं, तो यहाँ पे facet joints सारे destroy हुए हैं. And this is classical facet arthropathy, synovial lining अच्छी है दिख रही है, joints asymmetrical हैं, joints का size बड़ा है, size बड़ा होने की वजह से canal. अच्छा, and this is also taken at the level of the foramen, and you can see here कि canal के साथ ये nerve fibers, nerves यहाँ पे exit हो रही हैं. The other thing you can see on this axial view compared to the previous one, एक spinous process है तो center में, लेकिन यहाँ पे deficient है. And this is a post-op MRI scan which shows कि यहाँ पे किसी stage पे surgery हुई है, और spinous process और lamina जो है यहाँ पे drill किया हुआ है, तो यहाँ पे lamina absent है. Also, what you see here compared to the previous one, अब यहाँ पे इनकी muscles देखें patient की, these are young healthy muscles, dense and symmetrical. On the other hand, यहाँ पे and muscles on T2 weighted images will look iso intense, and the fat will look hyper intense, right? So तो यहाँ पे अगर मसल देखें, so this a lot more fat and probably यहाँ पे scarring होगी because surgery हुई है, and a lot less iso intense. So यहाँ पे muscles भी they're smaller, they're more shrunken, even sauce भी atrophic हैं, यहाँ पे भी muscles shrink हुई हैं quadrilaters. और यहाँ पे देखें, if you go back, यहाँ पे किस तरह सारी muscles जो हैं bones पे attached हैं, right? यहाँ पे joints पे attached सारी muscles. इधर देखें तो यहाँ से लग रहा है कि बोन से भी सेपरेट हुई हुई है, लेमिना से सेपरेट हुई हुई है, जॉइंट सेपरेट हुई है. So at some stage this patient underwent surgery and the muscles were peeled away from the spinous, the lamina and the spinous processes, and of course they will never heal as well as the patient with the who hasn't had surgery. And this goes true for any part of the body. Once it is intruded, it never heals back to its preoperative status, although patients may not be symptomatic. Right, and that's another axial view. So it's still 20 minutes, but so it's another axial view. As you can see, ये जो है ना pedicles के level से लिया गया, and so यहाँ पे joints are smaller. You can see the joints here. In joints में you can see that the distance between the joints is more than what we see in the previous images. अच्छा, हम नीचे आ गए तो यहाँ पे you see या ऊपर चले गए तो यहाँ you see smaller lamina and the spinous process in the middle, and the muscles are intact. Muscles look healthy, but here you can see the transverse processes जो हमें all levels पर नहीं देख रहे थे. ठीक है, and इसकी and also you will notice that the canal is spacious here. There is enough space here, and the fat is visible. The ligament of flavum is thick. यहाँ पे देखें ligament of flavum नजर आ रहे हैं आप पे. So पिछले से मुकाबले में thick है ये. यहाँ के मुकाबले में ligament of flavum are thicker, but still not so thick that they're encroaching on the canal or compressing the canal. And that's a CT scan image, again mid-sagittal view, which shows the bone. So this is CT scan, we know this because it looks like a CT scan, of course. So this is the bones here that don't look as dense as they should, and so this is an osteoporotic spine. और यहाँ पे आपको lines दिख रही हैं, which is called which is the typical lines you see in osteoporosis, and also mid-sagittal because you see the spinous processes here. But good disc heights, good angle, good lordosis. ये sagittal view ka, it's more on the lateral side. So this is not mid-sagittal. This is a section through the pedicles, and this is how the pedicles look like, or this is how a facet joints would look like on a sagittal view. So that's the superior. So ये facet joint का क्या करते हैं facet joints के lock करते हैं ऊपर और नीचे के spinous levels को. So this is 5, 4. So ये and 3. So ये L3, 4 का facet joints. So L3, 4 के में दो आपको facet L3, 4 पे जो facet joint होगा, it's formed by the superior facet of the inferior level and the inferior facet of the superior level, and so that locks the L3 on the L4 vertebra. और अगर ये joints खराब हो जाते हैं तो ये anterior motion becomes more possible. अच्छा, ये pedicle के नीचे ये foramen होता है जहाँ से nerve निकल रही होती है. यहाँ देखें कितना spacious foramen है. Now, if the vertebral disc heights become narrow और कम हो जाए किसी वजह से, तो you will notice कि ये foramen भी कम हो जाएगा इससे, right? इसी तरह अगर ये facet joint बड़ा होना शुरू हो जाए तो उससे भी foramen narrow होना शुरू हो जाएगा. Okay. That's another view through the pedicles, and you see how the pedicles connect the lamina all the way to the vertebral bodies. That's the so that's the strongest structure of the lumbar spine, the pedicles, and that's why जब हम इसको fix करते हैं, screw करते हैं, तो we go through the pedicles, which gives you access to all the entire length of the vertebral body and the posterior elements. In fact, जब पहले spine को हम लोग divide करते थे trauma में, तो इसमें 3 columns में divide करते थे, जो अभी भी लोग बात करते हैं, but it's less mechanically valid now. तो उसमें ये होता था कि anterior spinal ligaments, anterior half of the vertebral body, the anterior half of the discs, including annulus fibrosus, would be included in the anterior column. Middle column would be the posterior half of the vertebral bodies. Posterior spinal ligaments would be the middle column, and the posterior columns would be the pedicles, the facet joints, the supraspinous and infraspinous ligaments. और पहले ये था कि अगर and this was the famous Dennis 3-column theory कि अगर दो columns involved in fracture में तो इसका मतलब है unstable spine. We know that it's no longer it's not applicable to firstly all fractures, and it's a rather simplistic explanation of spinal stability. अच्छा, डिस्क के साथ यहाँ पे ना these are end plates. अगर हम MRI sagittal में देखें, I don't know if we and so these are healthy end plates, and that's something else that you need to observe in MRI scans, that with degeneration the end plates start to show signs. जैसे यहाँ पे हमें दिख रहा है थोड़ी सी end plate में encroachment है, and इसमें आपको edema भी दिख सकता है, इसमें आपको fat formation भी दिख सकती है, right? Now these are all almost normal lumbar spines that we're seeing. We still haven't come to the pathologies. It's a CT scan of the axial CT scan from at the level of the pedicles. यहाँ पे किस तरह देखें कि bone anatomy कैसे नजर आ रही है. Spacious canal, again good muscles. The spinous process is partly visible, and the facet joints are clearly visible, and these are healthy facet joints. And broad lamina, and this is, look at the angle of the pedicle. किस तरह से spine में angle करते हैं. इसी ये अगर pedicle thoracic spine में देखेंगे तो this straighter, and that's why the thoracic spine is narrow. And look at the angle between the pedicles and the spinous, the transverse processes. And so जब pedicle screws कर रहे होते हैं हम, तो ये important landmark होता है. It's a junction between the facet joints and the transverse process, which gives you direct access to the lamina, to the pedicle. X-rays are old technology, but still very relevant and very useful in a lot of conditions. It is no longer the first line investigation we do to investigate a patient with back problems, but it's more of a supplemental investigation for neurosurgeons, for spine surgeons. But a lot of information can be derived from the X-rays, for example, the alignment. And you can see the perfect alignment of this lumbar spine here. And जो हमने अभी डिस्कस किया था, यहाँ पे भी एक्सरे में आपको नजर आ रहे हैं, these are spinous processes, right? ये आपको end plates दिख रही हैं, ये vertebral bodies दिख रही हैं, ये जो आपको आँख की तरह से दिख रहे हैं दो, so अगर यूँ देखें तो ये दो आँखें और ये नाक उल्लू के मुंह की तरह, तो these are the pedicles जिसका आपको end on view दिख रहा है, and big size pedicles है, ये transverse process दिख रहे हैं, ठीक है, और ये नीचे facet joints हैं, and that's how the अगर जो हम पेडिकल स्क्रू की बात कर रहे थे कि जो इजी लैंडमार्क है वो फेसेट और ट्रांसवर्स प्रोसेस के जंक्शन पे इट्स गोज डायरेक्टली इनटू द पेडिकल, राइट? ये लेमिना दिख रही है यहाँ पे, और ये बीच में दिस इज वेयर द लिगामेंट फ्लेवम वुड बी. ये इंफीरियर लेमिना है ऑफ द L3 वर्टिब्रल बॉडी, L3, 4, 5 नहीं सॉरी L4, 5, S1. तो ये इंफीरियर लेमिना, ये L4 की लेमिना है, ये L5 की लेमिना आनी शुरू हो गई, और इतनी स्पेस होती है दोनों लेमिना में, ठीक है. सो जब आप डिस्क सर्जरी करते हैं तो आप इसी स्पेस में जाते हैं, तो इसमें we drill lamina, so we want to go to the attachment of the ligament of flavum, but this is essentially the space that you want to go. And lateral आप जाते हैं तो ये पास इंटरआर्टिकुलरिस है, तो lateral आप जाते हैं इसमें ख्याल रखते हैं अगर ज्यादा lateral जाएंगे तो आप ये पूरा पास फ्रैक्चर कर सकते हैं, जिसकी वजह से स्पाइनल इंस्टेबिलिटी हो सकती है. lateral view है इसमें एक्सरे का, इसमें भी वही स्ट्रक्चर जो हमने बात की थी, the pedicles, the vertebral bodies, the foramen, the facet joints, and the spinous processes. Right. Now coming to pathologies, and again this is not a mid-sagittal view, but why? Because you don't see the spinous processes. In fact, आपको facets का एक part दिख रहा है यहाँ पे. So that's how you tell कि mid-sagittal view है नहीं. And these are all healthy discs. लेकिन यहाँ पे आप देखें disc is dehydrated. It's not entirely white. It is partly black, and there's a large disc fragment which is slipped out and got into the canal, right? And clearly visible. And this is essentially what a big disc herniation would look like. Now there are many grades of disc herniations, and disc herniation is a is a pathology of mostly young people. So you would see disc herniations in patients from the range of 20 years to 40, 45 years. Why? Because as you grow older, a couple of things happen. Yes, the annulus fibrosus becomes weaker. So there's potentially more risk of disc herniation, but at the same time, the nucleus pulposus loses its viscosity, loses its strength. So that also degenerates. So there isn't enough nucleus pulposus to herniate out. And the disc height becomes narrower, the spine becomes less flexible, more rigid. So as patients age, the discs no longer have a tendency to herniate. And so old age की pathology is different है, वो degeneration related है, उसमें spinal stenosis होता है, lateral stenosis होता है. Young age में ज़्यादा common होती हैं disc herniations. And we see this a lot. और इसमें symptoms क्या होंगे? अच्छा, ये इसका axial view है disc herniation का. You see again going over the anatomy. इस anatomy और बाकी patients में क्या difference है? You see the muscles are smaller. On the other hand, you see this thick layer of fat here. So this is a rather क्या कहना चाहिए? Well, fat patient, let's say, and again disc herniation. Now the disc होती है वो commonly so this is the posterior part, this is the lateral part. So this commonly is the posterior lateral part. And why? Because this is where the annulus fibrosus is weakest, the posterior lateral junction. So commonly discs जो होती है posterior lateral part में herniate करते हैं. Because posterior lateral part में herniate करती हैं, यहाँ से जो nerve गुजर रही होती है उस पे preferentially encroach करती है और उसके symptoms होती हैं. और ये symptoms जहाँ जहाँ nerve supply कर रही होती है वहाँ symptoms होंगे. So अगर L5 है, so contralateral side पे देखें तो ये यहाँ पे nerve दिखनी शुरू होगी है facet joint के नीचे, और right पे नहीं दिख रही है because जिसकी वजह से वो obstructed है.
There we have one relevant question. Wasif Malik wanted to request that please elaborate lateral recess.
Okay, Wasif. So I'm not going to classify modic changes. We can, because it's a relevant topic, like, and it's going to take a lot of time, and we want to talk about the common things first. But modic changes, चले हम उसकी बात करते हैं. So lateral recess कहाँ पे होती है? Now, let me find a good image. Right. So अगर यहाँ पे देखें ना ये so this is the central canal, और इसमें lateral recess क्या होता है? It's a space on the lateral side of the canal, right? और ये ऐसे बनती है कि जो facet joints होते हैं और ligament होते हैं उसको जैसे जैसे आप canal, because ये बिल्कुल गोल नहीं है, right? ये गोल है और साइडों पे जाके नैरो होती है जहाँ पे नर्व आती है और फिर वो नर्व वहाँ से एग्जिट होती है और बाकी नर्व वहाँ नीचे गुजर रही होती है. सो जैसे आप साइड्स पे जा रहे हो कैनाल में जाते हैं, इट बिकम्स नैरो एंड नैरो, और दिस इज द प्लेस वेयर and this is it's properly measured on CT scans with the distance between the facet joints and the vertebral bodies or discs, and इस जगह पे आके the canal is the narrowest and this is the lateral recess. अब lateral recess की importance ये है, I think I have that illustration. So lateral recess की importance ये है कि यहाँ से आपकी nerve root जो होती है वो निकल रही होती है before it exits. Right? So वापस जाते हैं. So जैसे हमने बात की थी कि जब facets बड़े होते हैं और ligament of flavum thick होते हैं, तो जो सबसे पहले जो चीज नैरो होती है वो ये lateral recesses नैरो होती है, बिकॉज वो facets बड़े होकर सबसे पहले उसको encroach करते हैं, ligament of flavum बड़े होकर उनको encroach करते हैं, especially facets. तो उसको hang करने की वजह से इस recess को नैरो कर देते हैं और उसकी वजह से जो आपकी both traversing and exiting nerve roots, especially the traversing nerve roots, उसकी जगह तंग हो जाती है और फिर वो प्रेस हो रही होती है. And remember we talked about the circular, इसीलिए जो spinal stenosis जब होता है तो उसमें instead of a round canal you see a triangular canal. That's because ये lateral recess है, because the recess becomes narrow. ठीक है, recess almost खत्म हो गई तो आपको ये triangular दिखना शुरू हो गया. So yeah. So coming back to disc herniations, actually this is more of a spinal stenosis में ज़्यादा involved होता है. But disc herniations पे आते हैं अभी. So that's a posterior lateral disc herniation. So ये अगर L4-5 पे disc herniation होगी, so ये L5 nerve root जो यहाँ से traversing nerve root होती है उसको affect करेगी, exiting nerve root को नहीं करेगी. Again, disc herniation at the posterior lateral junction. It's a bigger disc herniation. पूरी स्पाइनल नर्व्स को आगे पुश किया हुआ है. ये राइट की नर्व दिख रही है आपको थोड़ी सी, लेफ्ट की नजर नहीं आ रही क्लियरली. दिस माइट बी इट. दिस इज अ लेवल लिटिल बिलो द स्पाइनस प्रोसेस. एज यू कैन सी यहाँ पे स्पाइनस प्रोसेस नहीं दिख रहा, लेमिना कम दिख रहे हैं, नीचे फैसेट बड़े दिख रहे हैं यहाँ पे. Right, so we talked about exiting, traversing and exiting nerve root. So let's assume that this is an L4-5 level. That is where the disc herniations are commonest. And second, uske baad L5S1. So you can see, so ye, and this is a cut through the canal. So यहाँ पे pedicles दिख रहे हैं आपको. ये जो nerve दिख रही है, so ये L4 है, ये L5 है, right? So और ये L4-5 की disc है. तो ये जो nerve दिख रही है, that's the exiting nerve root. So L4 nerve root L4-5 लेवल से निकल रही होती है, सही? और ये L5 nerve root जा रही होगी जो L5S1 के लेवल से निकलेगी. So जब normal disc herniations होती हैं posterior lateral, the exiting nerve root is not involved. The traversing nerve root is involved. So L4-5 nerve root पे जो L4-5 disc herniation जो है वो L5 nerve root को symptoms cause करेगी, and that is what you see commonly. So अगर central type disc herniation हो या posterior lateral disc herniation हो या paracentral disc herniation हो, that will preferentially cause symptoms at the traversing nerve root. So अगर L4-5 पे है तो L5 पे symptoms करेगी, L5S1 पे है तो S1 के symptoms cause करेगी. On the other hand, if you have a disc which superiorly migrates, or a disc which laterally migrates, or you have a far lateral disc or a foraminal disc, that will cause symptoms at the exiting nerve root. So अगर L4-5 पे superior migration है या far lateral disc है या foraminal disc है, that will cause symptoms on L4. Otherwise, the symptoms will be on L5. Was I clear in that?
Yes, sir.
I think absolutely clear, because this concept is really important.
ठीक है, तो ज़ियाउल्लाह आपके सवाल का ये जवाब हो गया.
Yeah.
And that is important because you see, more importantly than in other parts of the body, spine surgery may, because it's so common to have pathological pathologies which are asymptomatic. So healthy patients can have a little bit of herniated disc or a little bit of stenosis, and you don't need to treat these things. So it's so important to be able to correlate patients' symptoms with radiology so as to know exactly which level to treat. And that is why it's extremely important that the symptoms should match the pathology. So if you have a disc herniation at L5S1 level, but the patient comes with back pain, the disc surgery will not improve the back pain, right? Or if you have an L5S1 disc herniation on the right side and the patient comes with the L4-5 symptoms of left side, you will not operate because on that disc, because it will not make the patient better. So it's extremely important that in every single case, you're able to correlate the patient's symptoms with the pathology that you see on the MRI before you decide that I need to treat the symptoms. So यहाँ पे आप देखें, again disc herniation, but this is the lower level below. So ये यहाँ पे joints नहीं दिख रहे आपको, TP नहीं दिख रहे, right का nerve दिख रही है, left की ये दिख रही है और ये disc नीचे आई है. So this is probably a migrated fragment, and migrated fragment का क्या concept है? So as you see here, this disc herniation, like the fragment has gone downwards. It's still connected to the primary disc, but it's migrated downwards. So इसमें symptoms आपको मुख्तलिफ मिल सकते हैं. Thank you for the kind words, Dr. Altaf. Right. and there are many ways जिस पे disc herniations को classify किया हुआ है. It's not clinically relevant. Some people have tried to associate this with the natural history of disc herniations, and it makes a little sense. But radiologists, and my due respects to my colleague Kiran Hilal, but radiologists like to make a big deal out of it. So generally disc degeneration is any patient जिसमें आपको height कम हो disc की, आप उसको और बाकी degeneration के signs हो, facet hypertrophy, ligamentum hypertrophy, उसमें degeneration कह सकते हैं, and quick changes of motor type, उसमें अभी disc degeneration कह सकते हैं. On the other hand, a prolapse is where the disc goes beyond the posterior spinal ligament, उसको आप prolapse कहते हैं. अगर वो आपको annular tear भी दिख रहा है तो यहाँ पे देखें, this is annulus fibrosus जिसको illustrate किया हुआ है, and that's the nucleus pulposus. So अगर आपको annular tear भी दिख रहा है जो कि कभी-कभी दिखता है, वहाँ पे थोड़ा सा blood का drop दिखता है, तो tear के साथ अगर है तो उसको disc extrusion लोग कहते हैं, but still connected to the main disc. So extruded disc is connected, but herniates beyond the posterior spinal ligament and comes into the canal. Sequestered fragments are which जो कि यहाँ से migrate करके आ जाते हैं और disconnect हो जाते हैं primary उससे. So अपनी जगह से हट गए, अपनी disc level से हट गए और disconnect हो गया primary उससे, उसको sequestered fragment कहते हैं. As I said, this of academic nature. It doesn't help you decide which patients to operate or not to operate. So Ziya ne pucha, when are we going to operate a patient having disc symptoms? The decision will be purely on clinical. Yes, the answer to your question, Ziya, is the decision is never ever radiological. It's always clinical. So generally, the natural history of the disc herniation ki young patients, you will have a young patient in your clinic with sudden onset acute pain, radiating down to the leg in the distribution of the fragments, or the S1 ka pain so going back the hip behind the thigh, L5 ka hai to lateral aspect of the thigh, and L4 ka the front. So वो होता है, short history होती है, severe pain होता है, and the natural history of disc herniation is that in 6 to 8 weeks, almost 85% of the patients will be asymptomatic. So unless the symptoms are severe or unless there is progressive neurological deficits, we do not offer surgery beyond before 8 weeks of symptoms, because we know 85% patients will get better without the need for surgery. If you look at the natural course beyond 8 weeks, and there are many studies to show this, and there are many interesting stories behind it. At 2 years, the outcome, so if you have a patient with disc herniation and a patient you manage conservatively versus somebody who you operate, the 2-year outcome of patients who are operated is the same as those who are managed conservatively. So 2 साल में जितनी बड़ी भी disc हो, जो भी symptom वो eventually ठीक हो ही जाते हैं. That's what the data suggests. Of course, so the decision to operate entirely is on symptoms. If the symptoms are severe, you will not wait 2 years for them to resolve, right? And also these are young patients, they're active patients, and if the symptoms affect their quality of life, then you offer surgery up front. If the symptoms are manageable, so you know कि अब ये इसको time दे तो ये 8 हफ्तों में या तो 85% में ठीक हो जाए, वरना 2 साल में तो ठीक हो ही जाएगा, right? The only indication of early surgery is if the pain is severe, the symptoms are severe, the patient does not want to wait longer for natural resolution of symptoms. If there is progressive neurological deficit, कि अगर भाई foot drop होना शुरू हो गया patient को, ठीक है, तो आप wait नहीं करते, पहले surgery करते हैं. And the most definite indication for early surgery is quad icona syndrome. When there's a central disc compressing on the quad icona and patient have symptoms of sidal anesthesia or bladder bowel dysfunction, उसमें आप quad icona पे yes Hani, thank you, उसमें you do not wait, and that is a quad icona is actually an acute surgical emergency, because उसमें time really matters, because leg के symptoms, leg के deficit reverse भी हो सकता है, लेकिन quad icona में if you delay it, the symptoms may be irreversible. So that's the natural history of disc herniations. Now compare this to the other pathology that we're going to talk about, is the spinal stenosis. So disc herniation, as we talked, is acute onset, young patients, reversible most of the times. Spinal stenosis is a degenerative process, right? And it takes years and years to develop, and this is not reversible. So this is a stenosis segment. यहाँ पे canal, you can see that the joints are bigger, the capsules are bigger, the joints are asymmetrical. Although lamina are still visible, they can. Old patient है तो muscles भी आपको fat ज़्यादा दिखना शुरू हो गया है. The ligamentum flavum is very thick, right? जिसकी वजह से the lateral recess is totally stenotic. तो central stenosis इतना नहीं है क्योंकि आप पीछे अभी भी fat नजर आ रहा है, लेकिन lateral recess जो वासिफ पूछ रहे थे, lateral recess बिल्कुल stenosis हो गई है, जिसकी वजह से जो traversing nerve root होगी वो बिल्कुल press हुई होगी. और इसमें symptoms क्या होते हैं? इसमें acute onset symptoms हो तो सकते हैं, लेकिन more commonly patient present with progressively worsening walking dip. So patients ये कहते हैं कि हम चलने पे ना पाँव थकने शुरू हो गए हैं, जल्दी सुन होने शुरू हो गए हैं. And there's a tendency to bend forwards when walking, because when the patients bend forward, the ligamentum flavum gives way, and there's a little more space in the canal for the nerves. Similarly, patients कहते हैं कि walk करते हुए leg के symptoms उनको होते शुरू होते हैं, जो भाई paresthesias or numbness or the tingling or the pain, जो इन nerve roots के symptoms, और वो walking पे worse होते हैं, rest पे improve हो जाते हैं, sitting पे improve हो जाते हैं, bending forward पे improve हो जाते हैं, लेटने पे खत्म हो जाते हैं, सोते में. And this is progressively worsening over months, over years, and the walking distance is becoming less and less. So, and that's what we call a neurogenic claudication, which is similar to vascular claudication in a lot of ways. So neurogenic claudication se present karte hain patients, radiculopathy se present nahi karte. Radiculopathy is when you have pain in the distribution of the nerve root. Stenosis when you have claudication. Claudication is when you have stenosis की वजह से walking difficulty and decrease in walking distance. So disc herniation में जैसे मैंने बताया, majority में आप conservative management में ठीक हो जाते हैं. Stenosis में जो data ये suggest करता है वो ये कि if the patients are symptomatic, again इसमें भी treatment symptomatic होती है, doesn't matter how bad the stenosis is on the MRI. अगर symptoms manageable, you don't offer surgery. If the patient's quality of life is impaired, the walking distance is getting less and less, and the patient himself says कि भाई अब नहीं चला जाता, तो then you offer surgery. Disc herniation में the goal of surgery is to just remove the herniated disc fragment and see the nerve root. यहाँ पे the goal of surgery is to decompress the canal, open the entire spinal canal, and make sure that the lateral recesses are open. तो इसमें सर्जरी करने में आप कई दफा facet joint का भी कुछ पार्ट ड्रिल करना पड़ता है to make sure कि आप पूरा ligamentum flavum निकालें. अच्छा, ligamentum flavum का एक और ये होता है कि just you know what we talked about कि inferior lamina पे लगे होते हैं और superior lamina के अंदर लगे होते हैं inferior lamina के ऊपर. तो जब इंसान MRI तो आप लेट के करते हैं ना, तो जब इंसान सीधा खड़ा होता है और बैक स्ट्रेट करता है तो there is an in-buckling of the ligamentum flavum. So these stenosis become more symptomatic when the patient is standing erect because there is an in-buckling. So even you will notice that in a lot of patients there's borderline stenosis on the MRI scan, but they're more symptomatic. Even in those patients you offer surgery. And these are typically older patients. So that's the difference between a disc herniation, natural normal canal, and a stenotic canal. You can see that the size of the facet joints, kitna fark hai, the angle of the facet joints change. The space between the two joints is increased, so you see more synovial lining. The ligamentum flavum especially becomes very thick, and the canal is becoming less and less prominent, and the lateral recesses are almost non-existent. और कई दफा इतना स्टेनोसिस होता है कि आपको नर्व्स दिख ही नहीं रही होती हैं, CSF दिख ही नहीं रहा होता है, बिल्कुल बंद होती है ये जगह. Right? And that's a sagittal view of spinal stenosis. Achha, so stenosis doesn't happen in isolation. It's part of a process, degenerative process, and it can involve one motion segment, but it will never happen कि भाई सिर्फ ligament thick हो गया, सिर्फ canal narrow हो गई. So there are usually other things involved. For example, in this case, अच्छा disc herniation में आपने देखा सिर्फ disc निकली होती है, बाकी पीछे बीच anatomy सब सही है. यहाँ पे so there is some prominent disc over here. There's a little bit of listhesis over here, but also the ligament is thick from the back, एंड इस लेवल पे बाकी लेवल के मुकाबले में द कैनाल इज नैरो, एंगल की वजह से सही, लेकिन द कैनाल इज नैरो देन अदर लेवल्स. So stenosis is always part of a degenerative process and doesn't happen in isolation. ठीक है. यहाँ पे जैसे देखें कि एक जगह स्टेनोसिस है लेकिन बाकी जगहों पे भी डिजेनरेशन हुई है. This is not a very good quality MRI scan. So just go ahead. Now this is also stenosis, severe stenosis है. ये देखें सारी कैनाल स्पेशियस है ऊपर, और लेकिन यहाँ पे आके severe stenosis है. However, if you look at the reason, यहाँ पे disc reason नहीं है. Yes, ligamentum flavum thick है, but this is again a degenerative process which has gone beyond what you normally see. और यहाँ पे ना सिर्फ ये कि disc height खत्म हो गई है, but there is also listhesis, and that's our next topic, spondylolisthesis, when one vertebral body is slipped over the other vertebral body. And listhesis, and we can go into more details because it depends on a lot of things. More commonly the integrity of the pars interarticularis, and can happen because of an elongated pars or a fractured pars. But more commonly degenerative listhesis जो हम देखते हैं वो fractured pars के साथ होता है. And a lot of people think that this is a congenital condition which manifests itself as people age. But essentially what happens is that one vertebral body slips over the other vertebral body, which leads to तो उसको compensate करने के लिए बाकी body क्या करेगी? जो हमने बात की ना posterior ligaments structures होते हैं, उसमें facet joints होते हैं बहुत important. Facet joints उसको compensate करने के लिए या उसको prevent करने के लिए they become thicker. And they become more enlarged, more hypertrophied. उसकी वजह से और canal narrow होती है. जब फिर आपके ligaments become thicker, तो उससे और canal narrow होती है. फिर because listhesis हो रहा होता है, ligaments thick हो रहे होते हैं, disc height कम हो रही होती है, तो foramen narrow होना शुरू हो जाते हैं. उससे और आपको symptoms stenosis के मिलते हैं. The other thing you see here is this is an end plate change. And it's not a typical modic, but this is more like Schmoller's node. That's a CT scan of lumbar listhesis, and you can see ये जो black दिख रहा है, this is air, and that's what we call a vacuum phenomena. Again, it signifies advanced degeneration. और ये बाकी यहाँ पे levels ठीक है. यहाँ पे देखें तो इसके height भी narrow हुई है. There's listhesis, there's slippage of one vertebra over the other, and as a result, even though the canal is not that narrow, but because the angle is changed, the exiting nerve roots become stretched. So foramen भी narrow हो गया, nerve roots भी stretch हो रही थी, तो it becomes more symptomatic. और जो stenosis में हम कर रहे थे कि हम disc herniation में सिर्फ disc निकाल रहे थे उसको treat करने के लिए. Stenosis में हम लोग सिर्फ canal को wide कर रहे थे. अगर इसकी सर्जरी करनी पड़ती है तो आपको इस जगह को ना सिर्फ ये कि डिस्क हाइट को आपको इम्प्रूव करना पड़ता है नर्व को फ्री करने के लिए, आपको लिस्थीसिस को रिवर्स करना पड़ता है एज मच एज यू कैन, आपको कैनाल को भी वाइड करना पड़ता है, और आपको इस जगह को फिक्स भी करना पड़ता है कि इट डजंट रिकर. सो इट्स अ मोर एक्सटेंसिव ऑपरेशन, बट अगेन स्टिल सेफ. और ये लिस्थीसिस वाले लेवल पे आपको नजर आएगा स्पाइन में. सो देयर इज नो सेंट्रल स्टेनोसिस. यूजुअली लिस्थीसिस में यू डोंट सी सेंट्रल स्टेनोसिस. But there is a significant lateral recess. यहाँ पे देखें lateral recess जो वकास पूछ रहे थे वो बिल्कुल नजर भी नहीं आ रही. Hypertrophied facet है, hypertrophied ligamentum flavum है, और lateral recess बिल्कुल खत्म हो गया. And at the same time, because of the listhesis, the foramens are stretched, और तो उसकी वजह से भी there is a lot of pressure on the nerves. So इसमें अगर आप सिर्फ laminectomy करेंगे तो listhesis worse हो जाएगा. दूसरा ये कि it will not free the nerves, it will not free the foramen, so these patients will not get better. और इसकी जो typical usual classification हम follow करते हैं, और yeah, so what grade of listhesis require fixation? So Fazan, grade जो है ना, it's interesting. For example, and that's a 1 hour lecture by itself, listhesis का, because listhesis की natural history जो है, जो progression है, that depends on, अव्वल तो ये कि इसकी ट्रीटमेंट ओनली डिपेंड्स ऑन सिम्टम्स, राइट? जैसे हमने बाकी स्पाइन में बात की. अगर लिस्थीसिस है, सिम्टम्स नहीं है, पेशेंट चल हॉकी खेल रहा है, तो क्या जरूरत है आपको ऑपरेट करने की? नहीं. अच्छा, स्पाइनल स्टेनोसिस में सिम्टम ने कहा था कि लेग की क्लॉडिकेशन के होते हैं, डिस्क हर्निएशन में लेग के रेडिकुलोपैथी के होते हैं. लिस्थीसिस में जो होते हैं वो क्लॉडिकेशन के भी होते हैं और बैक पेन के भी होते हैं. because it's a degenerative process or motion segment instability है. So अगर back pain भी है और leg pain भी, तब तो आप कहते हैं कि हाँ listhesis के symptoms है. Now अगर symptoms नहीं है आप उसको treat नहीं करते because जो उसकी natural history है. So degenerative listhesis for example does not progress beyond grade 2. ठीक है. आपने ये नहीं होता कि भाई एक आदमी है वो 60 साल का है तो उसको grade 1 listhesis है तो ये तो 65 साल में grade 2 हो जाएगा, 70 साल में grade 3 हो जाएगा. No, it does not progress like that. On the other hand जो congenital listhesis होते हैं elongated pulse की वजह की वजह से या traumatic होते हैं वो that can get worse over time. So it's not the grade of listhesis that requires fixation, it's just the symptoms and they have no symptoms. तो अगर grade 5 भी हो तो आप treat नहीं करते, ठीक है. और अगर symptoms हैं तो grade 1 भी है तो भी आप उसको treat करते हैं. And this is the Mayer-Ding classification if you're interested. जिसमें the listhesis is graded according to the proportion of vertebral body which slides over the proportion of the superior vertebral body that slides over the inferior vertebral body. Again, इसकी जो classification है, it's only academic. It does not influence your management कि भाई ये grade 3 है तो उसको surgery की ज़रूरत है. The treatment always depends on the patient's symptoms. Okay, and this is what we normally do. We put in screws on both vertebral bodies. We try and reduce as much as we can. We try and increase the height as much as we can. यहाँ पे देखें आप ये disc implant लगा हुआ है to give some height. It's not always possible because it's a chronic process, takes years and years to develop. So इसको reverse करने के अपने consequences होते हैं. Technical difficulties अपनी जगह, लेकिन you don't want to reverse something which the patient has developed over 40 years of time, right? So you just do a little bit. It's not you don't do the surgery for the for how the post-op X-ray will look like, but what the patient best needs. And I think this is my last slide. Okay, so any questions? हमारे पास 2 मिनट हैं अभी.
Thank you very much, sir, for your time. And